overbite cases are by far the most that go bad and go south and go really south fast. And I would just totally stay away from anywhere over 50% overbite, honestly.
Welcome to the Digital Smile Hub, the podcast that is dedicated to making clinical dentistry simple. Join us as we decode the complexities of dental care by providing actionable insights into the diverse aspects of clinical practice, the latest trends, and the newest technologies. Whether you're a seasoned clinician or just starting out of dental school, listen in on engaging discussions, expert interviews, and a wealth of tips and tricks to enhance your clinical workflows. So turn up that volume and get ready to transform your clinical practice with the Digital Smile Hub. And now, here's your host, Dr. Tim Anderson.
Welcome, everybody, to the Digital Smile Hub. I'm your host, Dr. Tim Anderson, and super excited to have you guys back this week. I don't know about you guys, but this week's been kind of crazy. Everything's been like back to school, and kids are getting back into the routines, and I think the realization is that in North Dakota, we're going to start having cold weather and all that garbage that happens this time of year. So, but one of the things, like, we were going through our practice in one of our team huddles, and one of the topics we always try to address in every team huddle is opportunities and situations and cases where, you know, are there patients within our schedule that could have treatment or may have the opportunity to say yes to the best or stuff like that. And one of the criteria that we always look for is aligners. And that got me thinking of like, hey, we got to talk about aligners. And I'm like, all right, who can we talk about aligners? And, you know, with 3D Dentists, we got so many good people that do so many amazing things. But I'm like, I want to talk to an orthodontist. And this week is really special to me because this is the very first episode. We actually have somebody in studio, which made me start to think like, shit, I need a studio name, I think. Like, I don't know what our studio is going to be. But this week, I'm actually joined by one of my local orthodontists, Dr. Thomas Welk, who's a local North Dakotan as well. And we're going to start talking to him about all things aligners, and more importantly, how we can start getting some of us that may not be doing aligners, or how we want to do more aligners, what we should be looking for specifically from the view of our orthodontist friends. So, Tom, welcome to the podcast, man.
Hey, thanks for having me. I'm a little nervous. My first podcast, but excited to be here.
Well, we couldn't tell right away. Like, for anybody who's never been on a podcast, like the very first thing when you put on like studio headphones, it sounds really weird to hear your voice.
That was horrible. I can't even watch videos of myself because I hate hearing my voice, and now I can hear it in my ears while I'm talking. So it's a weird feeling and concept, honestly.
So, Tom, talk to us a little bit about where, yeah, obviously I told everybody from North Dakota, but talk to us about like how long you been out of school, where'd you go to school, what kind of practice you're in right now, and what kind of dentistry you're doing.
Beautiful. I went to undergrad at University of Wisconsin in Madison, had an awesome time down there. Probably had a little bit too much fun. Played college golf there.
It's Madison. You played college golf.
Yeah.
Man, you know, here's the thing. I have my new dental partner, also Tom.
Tom thing.
Yeah, it's a Tom. He also is a big golfer, and I think like there's something about golf and dentists. Like every dentist either wants to be a better golfer, but you're actually a legit golfer. So you went to school for golf.
I played 5 years. I redshirted my first year and then lettered the next 4 and had a great time golfing and having a good time in Madison. Maybe too much fun. My first semester didn't go the greatest, and then got my life together a little bit. And, school kind of became more of a priority after that.
So where did you go to dental school then?
Iowa. So okay. I kind of bopped around the Big Ten schools, went to Iowa for...
You missed one of the better schools for undergrad. I don't know about dental school.
Yeah. Gross.
Oh, come on.
I don't know about that. Yeah,
everybody wants to be a gopher.
My wife went there. Does that count?
That does count.
All right. I met her at a Gopher Badger football game.
All right. So you went to Iowa for dental school. You finished dental school. I'm going to tell you guys, I don't know about everybody's experience in ortho and dental school, but my experience in dental school was awful. Like my courses taught me enough to make me never want to do ortho, because all I thought you could do with ortho was literally bend wire. I remember spending hours in lab trying to bend a stupid wire around teeth. And I'm like, nope, I'm out of this.
Well, at least you got to do that. I don't think we even got to touch wire. I think we had models and we had to measure how much crowding there was and then like come up with the angle classification. And it was like an old dude who had no idea. Like, I'm pretty sure he was trying not to teach us anything just so no one would try to do ortho as a general dentist. I think that was his goal.
Yeah, well, I literally look back, and that was the one course. And here's the thing, and I think this is an important lesson for any new clinician or even an older clinician who's been practicing a while. Like we often don't do certain procedures, not because we can't do it or that we don't have the skill set to do it. It's might just be we had a bad experience, or we had one bad outcome, and that kind of put us on a trajectory. Like literally, you guys, I thought I wanted to be an endodontist because I loved my endodontic experience at the University of Minnesota. Looking back now, I'm like, you couldn't pay me enough money to do endo all day. Not that there's anything wrong with doing endo all day. It's just not for me. But ironically, one of the areas that I hated, which was ortho, is now actually such a huge component of my practice that I really like. So what drove you into ortho?
Yeah, well, I grew up with my best friend's dad was Dr. Jesperson, who's an orthodontist. So I basically lived at their house.
He did my teeth, actually.
Yeah, he did mine too. And he had an awesome house. He had a pool table and a ping pong table in his basement and a big screen TV before big screen TVs were a thing. And he was golfing all the time and was just an awesome dude. And I was like, okay, this is pretty sweet.
You're like, this lifestyle looks great.
Yeah. And then he looked at my teeth, which were all messed up. I had a big diastema, and he was like, we got to fix your teeth. I go, well, I don't really care. Not only my parents want to pay for it. He's like, we're fixing your teeth. And then I got to experience all that, and I was like, this is sweet. So that's what got me interested in it. Sweet.
All right. So you fast forward. Where do you go to ortho school?
I stayed at Iowa. So I was there for 6 years.
Oh, man.
You know?
Well, it's better that than the Ohio State or something.
Yeah,
You Buckeyes are still tough.
I feel like the Hawkeyes are like...
Or Hawkeyes, sorry, not Buckeyes.
No. They're like a very benign school. It's like, I'm still a Madison fan for sure, but I'm like giving my Hawkeye buddies a hard time because they're just like mediocre at everything all the time.
Yeah. Well, so all right, so you get done with school, and then where do you go from there?
So I had the Dr. Jesperson connection and stayed in touch with him, and then my cousin married, who's also a dentist, married Dr. Holovit, who's, cousin by marriage. And he had a practice that he had started maybe another 4 years prior to that in Bismarck, and he had grown like crazy and was really busy.
Orthodontist or general?
He's an orthodontist, okay. Yep. And he was on me before he even got into dental school about coming back and joining him. And so we had kind of talked a little bit. I got into dental school. I was like, well, we'll see what happens in dental school. Peds was interesting to me. I liked endo too.
Man, you just named the two specialties with dentistry that I probably disliked the most. Yeah. Was peds and ortho.
I really liked endo, actually. I totally couldn't have done it all day long. I have a really bad back, and so dental school is really hard on me, honestly. Like, especially those 4-hour appointments where you're just like scaling and replaning for 4 hours on a poor patient that don't want to be there kind of deal, you know? So, but ortho, I'm really competitive. I grew up loving athletics and sports, and I wanted to be like really good at one thing, and general dentistry is overwhelming to me because there's so many things to be good at. And I wanted to really focus on something. And I like the idea of like problem solving and kind of taking something and trying to get to the finish line. And that's what orthodontics really is. And so it kind of just like stuck with me. And also I just like working with the younger kids. I hated peds because I didn't like talking to parents about not giving their kids sugary drinks, brushing their teeth. And I didn't want to give injections to kids all day. It's like scared me. So orthodontics was kind of a good in between. And honestly, like you're moving around all day long. You have quick appointments, 2-3 minutes, and then you're up and moving. And that was really good on my back. And nice. Yeah, I was lucky enough to get in, and I kind of just took it from there.
Sweet. And so one of the things I think that's kind of neat is, with newer generation of clinicians, ortho is one of those areas in dentistry that has seen a pretty big advancement as technology has gotten bigger and better and all that thing. And one of the things with the Digital Smile Hub is that we really focus on digital dentistry, and orthodontics has kind of had not only a evolution, but a revolution over the last 10, 15 years with regards to digital data and how you can manipulate digital data and move teeth. So, clearly you guys do a bunch of clear or straight wire bracket cases, but you guys also do a lot of aligners, and then you actually brought a surgical component to the practice. Talk to us a little bit about that.
Yeah, so we do TADs, temporary anchorage devices. I did a lot of those in residency. Our program director was like, hey, if they could use a TAD, do a TAD just so you get the experience. We got to do stuff on cadavers, which was really cool. So you got to place thousands of TADs and just get used to getting them in.
All right, you just orthodontist us for us basic people that don't understand what a temporary anchorage device, whatever the heck that is, what is a TAD?
So a TAD is like an implant, but it doesn't osseointegrate with the bone. So it's like literally just mechanical retention. You put it in between the roots of the teeth usually. There's a lot of different places you can put them. There's a lot of different things you can do with them. Some of the cool things that we do a lot of is for people with canted smiles, like that have a maxillary cant. You can put a couple TADs in on the side that hangs down lower than the other and intrude it and get it to level out. There's so many people walking around with gummy smiles, especially females. Like, it's so common. And I think so many of them don't know that it's treatable. And if they do think it's treatable, they think it's a jaw surgery, which it used to be for sure. It was a Lefort, which is a scary surgery.
Which I love that this is where innovation in technology really drives, workflows within our patients. Because prior to you coming to town, most of our cases, you guys think of like back in the day, there was like headgear and weird stuff you try to do during growth and development. But like literally it was a major surgery, or now we have the ability to literally under local anesthetic, put these tiny, they're literally like, you guys, they're like screws. They literally look like a little screw. You apply them like a little screw. It's pretty simple. Yeah. And it's one of those treatment modalities that offers so much benefit, but you just need to make sure people know that it's possible. So I think for me, that was one of those things I'm like, I needed to work with an orthodontist or a group that understands that this is even possible. Mm-hmm. Because a lot of orthodontists, nothing against you, man, but you guys don't like to get dirty.
Totally.
And so blood and needles and stuff like that is like, oh, I don't know. Like I literally, his partner, I'm like, do you even know how to give an anesthetic injection anymore? Like, I don't know if he does, but he does great with smiles. So it's kind of cool to see this new thing. So digital technology has really kind of been awesome. But one of the areas that I feel that digital technology, and I get really passionate about it, is the concept of how we've used intraoral scanners to digitize people's dentition. And not that is the amazing part. Like everybody thinks like, oh, that replaces the goop and, yay. But what's really amazing about that is that we now have the capability to use that digital data. And I think orthodontics was the first kind of, specialty to truly maximize the capability of what we could do with these STL scans. So you could take the scans, you can digitally move the teeth, segment that into multiple steps, and all of a sudden you can now print all of these, models to make aligners, and all of a sudden we can start moving teeth with aligners. Mm-hmm. So, and I think this really kind of opened the door and dropped one of the barriers. One of the things that 3D that I always kind of really talk with, newer clinicians or any clinician about is how do we remove the barriers to allow patients to say yes? Like, how do we get out of the way? How do we move things? And one of the things was like with orthos, like, I don't want to do wires. I don't want to do brackets. I don't want to screw up somebody's mouth. And aligners all of a sudden open this door for kind of what could happen. So talk to us a little bit, a little bit of an overview of what, like, for those that aren't doing clear aligners, like I think everybody knows what clear aligners are, like Invisalign, Sure Smile, Sparks, like all that kind of stuff. But talk to us a little about your practice in clear aligners, what it, when's a clear aligner case for you, what's not a clear aligner case, and kind of go from there.
Yeah, first off, I think orthodontics in general was like really fighting aligners because they thought it was a threat to braces, and just like anyone is, they don't like change, right? And so Invisalign really cracked that code and kind of went to general dentists too right away, which made the orthodontist eyes open up a lot, and it kind of blew up quick, honestly. And it has come so far from way back to 20 years ago when it started. But yeah, there's so much you can do with aligners, and some of it's harder than others. And I think it's the issue with general dentistry and doing some of this stuff is it's overwhelming to jump into a whole nother field because you're not sure what you need for it. You're not sure how to train your employees. You're not sure what do you do if something goes wrong, right? And so it's definitely overwhelming, and that's why I think case selection is huge as far as starting some of these cases. There's definitely levels of severity as far as correcting things with aligners. There's stuff you definitely don't want to do with aligners. There's stuff you can do with aligners, there's stuff you can't do with aligners. Honestly, a majority of it comes down to patient compliance and picking the right patient, because if they aren't going to wear them, it's not going to work,
Isn't that the truth?
And that is, people like the idea of aligners until they actually realize what it entails and how hard it is to maintain them, right? So it's kind of drilling that through their head before they sign on the dotted line and commit to it, because if they don't wear them, it's not going to work, and they're not going to be happy, and then you're going to be stuck with them for a long, long time, and it bogs down your practice. And we learned that really quick. We bought another practice in town, and there was a lot of people in treatment for many years. And oh man, just trying to talk through that was really interesting. So that's the number one. You got talking about compliance. Make sure they're that type of person that's motivated to get stuff done, especially with kids.
Well, I love what you said is that, like, you talked about case selection, and with 3D, that's one of the things we hammer on, is that we want to, case selection is everything. But also let's have a simple algorithm and simplify this whole thing. So one of the analogies we like to use is like creating a green light, a yellow light, red light case. So like green light case is like absolutely perfect starter case. Let's jump into that. Yellow might be like, hey, if you've got experience, give her a shot. Just be aware that this could go wrong or this could happen. And then red would be, maybe this is a better one to really have a conversation with your specialist and work with them or refer out. So let's talk about, like, in the case selection, like, what would be a green light case?
Yeah.
If I'm just getting into aligners, what's a green light case?
So the forces with that aligners use is a pushing force, right? So any sort of in and out movements of teeth, rotational movements of teeth, obviously the more minor it is, the easier it's going to be, right? You don't really want to jump into somebody who is really class 2 or really class 3 because you're going to mess up their occlusion, right? So class 1, mild crowding, relapse cases, people who had braces previously, those are really good ones to start with. Or if someone comes in and like, hey, I just don't like number 8. I'd say more yellow light cases are where you get to kind of controlling the vertical and changing the vertical. Like, let's say someone has laterals 7 and 10 that are a little bit too apical and they want you to extrude them for you. Well, laterals are just the hardest teeth to move with the liners. They're so conical shaped, and then extrusive movements are so hard, right? Then you get into attachment selection.
All right, I got to pause you right there. I need everybody who's ever tried doing aligners or wants to get into aligners to rewind this and listen again what Tom said, because do not try to extrude lateral incisors as your first case. It will drive you bonkers.
And everyone doesn't like their lateral incisors. And it's so hard. It's so hard to deal with laterals. And you have to have realistic expectations with them before they get into it, A lot of times if their laterals are small, which 35% of Caucasians are, right? You have to have a serious conversation about either doing buildups on them, veneers, and just kind of lining them up and dealing with the vertical that way. But yeah, laterals are hard. Canines are hard because they're conical, right? And so it's kind of just understanding some of these complex movements and trying to stay away from them if you can from a case selection standpoint, okay? The other part that is tricky is like vertical overbite, right? And so I'd say that's more like a yellow light case too, where you're starting to bang a little bit heavy on the incisors and you're starting to wear the lower anteriors. So you need to, essentially anyone with like a moderate curvature B, right? Moderate to severe are super hard aligner cases. So the issue, if you don't correct the curvature B, is you start to get posterior open bites with aligners, which I'm sure a lot of general dentists run into. And it's a lot of cases that we get referred from general dentists that have started aligner treatment, and they come in with just these massive posterior open bites, and those are really, really tricky to recover from. But a lot of times that has to do with premature anterior contacts from not leveling the curvature B, and also everyone's bite is wedge shaped, right? And so when you have plastic between your teeth, your back teeth are touching, and it's causing an intrusive effect on those molars. So naturally it creates a posterior open bite slightly, unless you can kind of fight to counteract that. So I'd say any overbite stuff, unless you're trying to get a little bit more advanced, I would stay away from with aligners for sure.
Yeah, especially as you're starting off, you guys, because I think Tom kind of mentioned like the cases that were always my first ones were just like you said. It was always the mom who's got kids that are either in ortho or whatever. It's always that patient where it's like they just can't justify spending the money and time on themselves. Or they didn't realize that it was something we could do in our office here. They thought they had to go somewhere else. So it was like, those are your best cases. Like somebody who's good class 1 occlusion, minor relapse, simple rotations, like those, man, there's such slam dunks.
Mild overbite. Look at overbite. That's a huge killer for aligner cases. You got to stay away from the deep bites for sure.
Yeah. And the other one that what's interesting that has become a bigger green light for my cases are actually pre-restorative or pre-prosthetic. movements. And so there's so many of our cases aesthetically on our cosmetic cases where, you know, if I leave the dentition where it is currently, I'm going to have to over reduce the heck out of these teeth. Or maybe it's going to be a crown case. Or it's something where I'm going to now be on cementum, or it's a crown lengthening issue or something like that, where now all of a sudden, if I have the ability to just correct slightly, it doesn't need to be perfect, just correct slightly. Now I can oftentimes take a crown case and make it a veneer case or something like that. So there are a lot of opportunities within your practice. And part of this is just being aware of your patient base, like looking at the teeth differently within your own practice, all of a sudden opens up this door of like, hey, I should try this.
Or to take that a step further, let's say you cement a crown and you have a little bit of space on the basilar distal, right? Like you're freaking out inside. You're like, oh gosh, what am I going to do, right? Print a couple of liners, close the space in about 7 days, and you're set.
I love that you said that. So we've all had that case where we did not take the excursive movements of occlusion into case when we did our second molars, and all of a sudden our tooth that was in contact is no longer in contact. And if somebody is like, that never happens to me, you're lying to me, because I know it happens. It happens to all of us. Or you see it around like an implant, or, you know, because implants don't move and natural teeth do. So if you don't manage the occlusion well, things can move around. But that's a great, I love that you said that. That's a great opportunity. Just do a couple of liners, push the tooth back in. Then you need to adjust the occlusion to get it out of that excursive issue. And then all of a sudden you took a situation where you'd have to cut off a restoration or redo it. And in a couple of liners, now they're done.
Yeah, think of the time and like chair side time and like having to reprint another crown or whatever, or remake it, like the overhead with that. And then the patient's annoyed. Man, it's such an easy solution.
So what would be like a big red flag?
Big red
We talked
flags.
about a little bit of the yellows and some of that. What's like a red flag where like even you are like, oh, this is going to be a total pain in the butt to do with liners?
Yeah, it's 100% overbites, right? Anytime you have somebody you're trying to fully correct, they're class 2 or class 3, and they want it fully corrected, it's just trickier to do with aligners. It just extends their treatment time, then you lose compliance. You know, I think the research shows that usually people are compliant with aligners for like 6 to 9 months, right? And so if you're trying to correct a 100% class 2 case and they have a mile of overjet, they just get burnt out with the aligners and doesn't work, you know? And so you can get it treated a little bit more effectively with braces, that kind of stuff, right? So it's doable for sure. Like I said, it all comes back to patient selection, making sure they're on board and motivated and that they understand what it entails before you get into it. But overbite cases are by far the most that go bad and go south and go really south fast. And I would just totally stay away from anywhere over 50% overbite, honestly.
I think I know that is like, we literally have a check box on when we're going through our analysis of these cases. And that's one of them that I'm like, nope, stay away. That is why we have our orthodontic buddies for that. But what I also think was interesting, you made a comment, and I never really thought about this because we've all seen this when we get into that revision hell, and we'll talk a little bit about revisions later. But patient fatigue with regards to like, people are human, and we've even seen this patient, like these cases when we have situations where we're doing cosmetic stuff where we've tried to match the shade perfect, and we're like on version number 6 of this anterior crown. And finally the patient's like, nope, it's fine. It's good. We're good to go. And it's that fatigue of like, I just need this done. And you guys see that all the time in ortho, and brackets is different because they're locked in, but aligners, what happens ends up, like what happens with these patients that get burnt out? Yeah,
I mean, I've done aligners on myself, and I totally have experienced fatigue with aligners. It is hard. You like start to convince yourself, like, hey, if I just wear these at night and a couple hours during the day, like, and I just extend the amount of days, like, I'll be fine. And no, you're losing everything you gain in those hours you don't have the aligners in, right? And so again, it comes back to, you got to know the patient. You got to like have a serious conversation with them up front, and then you got to expect them to start to get burnt out 6 to 9 months in. So you got to get as much done as you can in that first 6 to 9 months, right? And then you just have to be honest with them as they come back to see you for these refinements. You just got to say, hey, have you been wearing your trays as much as you should? And 9 out of 10 of them are going to be honest with you. Be like, I've been slacking lately. Like, I'm sorry, I'll be better. Or, hey, I can't do any more of this, right? And then at least because or else you get stuck in this endless cycle of let's make more trays, let's do it again, and then it just bogs down your clinic and your time, and they get frustrated with you. And even though they're not really mad at you, they know it's their own fault, but they want to blame somebody and they just want to be done. But then you have a subpar result and no one's happy, right? Like, I can't look at someone's teeth if they're not perfect and be happy about it, right? And so I think, sometimes there are the conversations where, hey, do we need to put you in braces to get you perfect, or what's the game plan forward? Can you motivate yourself to finish it up?
Yeah. So I think that really comes back to patient selection and good communication from the beginning. You guys really hammer that out from the beginning. All right. So we've got these green light cases, or maybe even some of these, a couple of yellow lights, but say the green light cases. And now whether we're submitting through Invisalign, SureSmile, whatever program it is, usually what ends up happening is we end up getting some form of ClinCheck or some digital design that we now, as a clinician, need to evaluate before. And I think this is one of those topics that honestly nobody talks about and is probably the most confusing, because I'll talk with some clinicians that literally, they're like, oh, I just hit go every time. And you'll talk to even some of the SureSmile and the Invisalign reps. They'll be like, yeah, there's a big bulk that just hit yes, and then they'll do the refinements later. You'll have others that will really dive into the weeds. Talk to us a little bit about what, as a new clinician who doesn't have a ton of experience, because honestly, a lot of these cases you learn through experience. Talk to us some of the things we should be looking for with a ClinCheck.
Yeah, man. I mean, how overwhelming is it to get a ClinCheck back? And there's so many movements going on, and there's random buttons all over the person's teeth. And what are these even doing? I have no idea why they're here, why they put them on. And then, depending on who the team is that designed the treatment plan, they usually don't have much training when it comes to moving teeth, right? And so you aren't sure the level of skill that these people have as far as who's designing your treatment plan, right? And so you get it back, you scroll through it kind of lines up the teeth. You're like, okay, we're kind of on to something, right? And then, but there's so much that you need to look at. And for me, I think the first thing I do is I scroll through it and I look at any unrealistic movements. Okay. So if they're trying to extrude the laterals 2 millimeters, it's not going to happen. Right. And so why accept the plan and then have them come back 10 weeks later and their laterals aren't tracking? It's just not going to happen. Right. And so you look for severe extrusive movements, any sort of crazy rotational movement. Let's say they're trying to rotate a premolar 45 degrees and there's not an attachment on it. Well, it's not going to happen either. Right. And so you look for the major red flags, and then you check out the attachments. I know that's probably down the road for a lot of general dentists, is understanding attachment shape and type for certain movements, but just make sure if your tooth is moving a lot, you have an attachment on it, especially if it's rotational, whatever it may be. And then I always look at Bolton discrepancies. That's a huge one. That's another major reason for posterior open bites, right? So I'd say, especially in the Midwest, it seems like there's so many people with small maxillary lateral incisors, and they have a Bolton discrepancy where you need to do IPR on the lower anteriors, right? And then I also think there's the flip end of that, where Invisalign or aligner companies just try to do IPR on every single person that walks in the door that isn't needed, and then they end up with excess overjet just because it's easier for them to move the teeth by creating some space around them, right? And so I look at the Bolton on every single case, and I kind of determine where I need to do IPR and when to do it, right? It's also a practice efficiency thing, is you don't want to have the IPR on tray 3 because then they have to come back 3 weeks later. Have it on tray 8 when they're 2 months in, and then they come back to see you to see how things are going. I also look at occlusal contacts on all the cases. I just have it going all the time because you never want to end with premature anterior contacts. And I also like to avoid contacts at the second molars, because sometimes for whatever reason the first molars intrude and you end up with contacts on the second molars only, and it is so hard to get those first molars back on track, right? And so no anterior contacts when we're done. Make sure I have at least enough overjet. I always overcorrect the overbite slightly, because as soon as you have those heavy anterior contacts, you're toast, in my opinion. So what else? I think as far as some of the rotational movements with central incisors, lateral incisors, I always like to overtreat those slightly. Plastic has give to it, right? And movements aren't always going to work out the way it shows in your ClinCheck. So I always slightly overtreat rotational movements and in and out movements. But honestly, like to make things simple, Bolton discrepancy, contacts for sure, and then make sure that the movements are realistic. Yeah. Those are the big ones.
So how often are you seeing your patients? Meaning, how many trays are you giving them? How long are they wearing them? And when are you seeing them back for evaluation?
Yeah, some orthodontists will do 2-week trays. You switch them every 2 weeks. I just don't find a need for it. I've done them on myself. I think every 7 days is fine. I think after 7 days, they lose their rigidity a little bit and you're not getting any movements out of it, right? I mean, if you chew on a tray long enough, you can get it to seat over a tooth, in my opinion, right? And so I think every 7 days is great. I like to see them back kind of like in the 8 to 12 week range. Depends on the complexity of the case. If they're wearing rubber bands or there's like, hey, I got to keep an eye on this person because they're a hard case. I want to see them back in 8 weeks to make sure things aren't going off the rails a little bit. If they're very responsible and it's a more straightforward case, you can kind of see them like every 3 months, which also opens up the schedule and as far as like an efficiency for your practice is really nice.
What percentage do you feel like of your cases? Because I think that's one of those things that GPs, maybe it was just me, but a lot of GPs thought was that like, oh my gosh, if you need a revision, like you did something bad or the patient did. Like, how many of your cases are you doing revisions in your aligners?
95% of them.
95.
Totally. Or,
did you guys hear
more.
that?
Or more.
95. So revisions are just part of the process. And I think you need to inform your patient. This comes back to that communication of like informing your patients, like, we're going to do this tray series and this is the first tray series.
Here's the analogy I use. I say, how often do you go play golf and make a hole in one on your first shot? Like never, right? It's like usually takes 3-4 shots to get in the hole, right? Same with aligners. You're never going to make it. Or
7 or 8.
You're rarely going to get it done in one shot, right? So those really mild cases, like that's more doable in one shot. But as you're kind of going through the complexity of the cases and you get harder stuff going, you're never going to get it done in one shot. Anyone that tells you that they do it, I can pick apart a million things that aren't right about it. If you want it to be good and have perfect occlusion, perfect alignment, it's going to take more than one set of trays. It's an imperfect thing. There's plastic, can only do so many things. There's give with it, and that's why, in my opinion, it's really hard to finish cases with aligners because certain rotational movements, in and out movements, it's just, you can't get them dialed in all the time in one shot. Sometimes those still take 2 or 3 refinements to get them perfect, and you're 98% of the way there to completing a case, but you ought to get it to that 100%, and it just takes a few minor tweaks, and they're hard to get out sometimes.
And I think we all just need to realize that that's just part of the process. That's part of just biology and anatomy and patient behavior and all that stuff, compliance. So it like refinements are just part of it. And so and what I love that you kind of like jumped over was the attachment aspect. And I agree. Like, I think sometimes we jump into these like rabbit holes of, it needs to be this shaped attachment. And yes, I think understanding basic attachment, what functions they do with regards to tooth movements is important. But honestly, like, I mean, you'll see some systems that are using like minimal to no attachments, others that like you got an attachment on every freaking tooth. And I think just finding that happy medium, the more you guys do this, the more you'll start realizing what works, what doesn't work. From the movement standpoint, you'll really start seeing if you're going to be doing any major rotational stuff, like you need just something to grab onto. If it's minimal tipping, that kind of thing, like, yeah, you're fine just pushing on it.
Yeah.
But I love that. One of the, the other area that can be difficult, so, we do all these liners, we do the ClinCheck, we send it off, we get all this case back. Like, talk to us a little bit about your guys' workflow. And I think this is important for everybody to hear from like the GP side, like the workflow of when cases come back, how you guys are applying the attachments, the IPR, when you're seeing patients back, how you're tracking it, how your team members are doing things, what the team members do, what they don't do. How does that work in your practice?
Yeah, I mean, that's huge for opening up your schedule. I think we have changed ours a lot in the last 2 to 3 years from an efficiency standpoint. We were seeing everybody back for every delivery appointment. Let's say they were getting a new set of trays in for refinement. If they had no new attachments, we still had an appointment slot in our schedule for them to come get their trays. But it's like, why would you add an appointment there when they can just come pick up their trays from the front desk and go on their way and not wait around for an appointment anyways, right? So as soon as the trays are in, front desk gives them a call, they come pick up their trays and they're rocking again, I like to schedule IPR for anywhere from that like 8 to 10 week intervals, just so, and that's the issue with Invisalign, right? They'll have, okay, tray number 3, we're doing IPR, then tray number 7, then tray 14. I like to do it all at once. Just from an efficiency standpoint, because it takes chairside time to do IPR. Why
do you like this? This is good. I like this. Is a good conversation. I think so. You prefer a little bit later into the sequence. Why do you prefer that? I've heard some other clinicians that are like, they want to do it day one, and like the day they put the attachments on, they're doing IPR as well.
Yeah.
Why?
There's a few reasons. That's a great question. So there's
kind of teeing them up here.
Yeah. I like to have the teeth straight, so I'm not gonna recontour their teeth in a messed up way, for sure. At least somewhat straight, because then I can get in there and do like efficient IPR. No, I'm not going to ledge anything or reshape their incisors and make them look really wonky in the long run. I also think patients are sometimes freaked out by IPR, and I always talk about it at the first appointment with them, like, hey, as your teeth line up, everyone's incisors are triangular shaped, and those points of the triangles are going to touch when they're straight, and you're going to have negative space underneath them where they're going to have black spots. And we're going to get rid of those by polishing the contact point and squeezing those teeth together.
Words matter, you guys. Notice what he said. He said polish it. We're not grinding away or shaving your teeth.
Polishing the contact points.
Polishing contacts.
Yep. And when they understand that, and then also when they see it happening, they're like, hey, I don't like these black spots, these black spaces, let's get rid of these things, and they're ready to rock, right? And then also think that IPR is, from an aesthetic standpoint, you can do so much good stuff with that. There's so many women out there, especially, that have
black triangles,
and they have very triangular shaped, like number 8 and 9. They hate the shape of their teeth, right? And so, you have 2.5 millimeters of enamel there, like interproximally. Like, why not go and recontour those for them and just like give them a more aesthetic look? And they love it. Like, that's why they don't like their teeth and they're not really sure how to describe it. And then you do it and they're like, this is awesome.
Well, I love the fact that, like, these are the conversations, like, as we're getting into these things that a lot of clinicians don't understand, because I didn't either. Like, I would get the report back, and the report would come back and it would say, IPR day 1, do all this. And then 3 trays later, do this. And for those of you who have tried to do IPR on significantly rotated teeth, it sucks. It is so hard to do.
Their heads are ripping around back and forth.
And you're like, please don't move so I don't cut your lip. And so what I love about that is that do it later, get the teeth into a better position so you have more control. And not only that, it's a lot easier. I mean, you'll be in and out of there a lot faster than if you were trying to do it when the teeth are completely overlapped. So totally. I kind of like that.
And they're freaked out. They get their attachments on their teeth that first day, and they're like, why am I doing this? There's so much new things in their mouth. And then you're like, hey, by the way, I'm going to take this sandpaper floss between your teeth. They're like, okay, this stinks.
So is this one of those things you're instructing to the aligner company when you're going through the ClinCheck? Like, hey, do IPR. If we need IPR, I only want it at this stage. Like, do you say that from the beginning, or is that just something you do later?
I just type it in right off the bat. I can tell when it's always in adults when they're going to have black triangles between their upper incisors and lower incisors, or if there's a Bolton discrepancy. And I just say, once the teeth are fairly aligned, please schedule IPR, preferably at tray 8. And then they'll come back, and let's say there's IPR. Let's say there's 16 trays, right? And so I want to see them one time at like tray 8. So I'm going to put it at tray 8. Or let's say there's 24 trays. Well, then I might be able to get them to 12, do IPR at tray 12, right? So I kind of see how many trays come back, and then I move it around based on that too.
Love it.
So I go back and forth with the technicians.
Like the little things that I'm like, this is why I needed you on here.
Yeah.
This is perfect.
Yeah.
All right. So talk to us a little bit about your team. So you guys are doing all this. Like, how does your team integrate into this workflow with regards to your team members, your assistants, your front team members? Like, how does this all work?
Yeah. So I like to do the initial treatment plan and go through everything on the aligner site and type in all my preferences of what I want the case to come out with. Okay. And then when they come back for refinements, I just give the assistant everything at the chair as far as what I want, and they go put it in there for me. So I don't have to spend that time on my computer doing that, because it's just work that anyone can do. Right. And so then I go in and do all the refinements. I am really type A, and I want to have control over all that, make sure nothing is getting missed. I know there's some orthodontists or dentists that have an assistant do their ClinChecks for them, and that gives me anxiety. And so I think that's how mistakes happen, and it just prolongs people's treatment, right? And so I do that, and then I just tell the assistants, like, hey, I want new attachments on these teeth, or I want IPR on tray 1 right away. Let's get them scheduled. Or, hey, if there's not any of that, let's have them come pick up their trays, and we'll get them in 8 to 10 weeks in. I also tell them what I want for rubber bands, how I want them wearing the rubber bands, how often I want them they're wearing the rubber bands. That way they have all the information they need and can get the patient in as efficiently as they can, so they're not waiting around a couple months to get another appointment. So I think the longer patients wait in between sets of trays, they lose that compliance factor, because they realize how nice it is to not have trays in for a little bit during the day, and then they are like, okay, I'm going to get my new trays and just wear them at night now, because this is easy.
So I'm going to give you guys a pro tip here. One of the things that we implemented that's worked really well, and you'll have some of those patients that are really motivated, but we live in this world where people like to make decisions like now, and they want to move and they want to start now. They want it today. And if you wait, say you scan them and then you send it off and you see them back 2 weeks later and you get the first aligner, sometimes people lose motivation, or life comes up, or kid needs a new whatever, and we lose that. So one of the things that works really well is the concept of day 1 first tray. meaning when they come in, they want to do aligners, you give them their first tray. And so the way we do this in our practice is every new patient gets we call it the hygiene trifecta, where it's a cone beam, it's an intraoral STL scan, and full muscle series of photos. So if we have a patient who's like motivated, who wants to do aligners, get them started that day. Say, you know what, if you want to do this, we can go straight today. And what they end up doing is they end up, putting their payment down and doing all that. We use their scan. We say, hey, come back in an hour or 2 hours or after lunch or whatever. And what we end up doing is taking the STL, and we're going to talk about this here in a second, but the traditional way, we would print a model and then use a pressure form and create that first tray. And the way we word this to the patients, they come back and like, this is your training tray. This is like the first tray to get you used to the material. So that way we aren't going to put pressure on the teeth. So it's not going to hurt. We just want you to get used to wearing it. So that way they're committed. And so they're committed day one, they walk out that door and they're ready to go through the whole process of submitting it, getting the ClinCheck and getting actually their aligners. So when they come back, then we do the abutment or the attachments, and then they've already been used to their tray. So
they know what they're getting themselves into.
Totally.
And so they could call you back 2 days later and be like, hey, I'm not doing this. This sucks.
Right.
Okay? And then you don't waste your money on submitting it to Invisalign.
And it's awesome because like we live in this world of like same day dentistry, and everybody thinks the same day dentistry is like crowns. Like, no, you can do this with occlusal guards. You can do this with retainers. You can do whatever. And so one of the cool areas that I got to dive into, because I was showing Thomas here this in our lab. We've been testing for Sprint Ray this new retainer material. And this, you guys, this is pretty cool because this is a direct print retainer material. So what this is we take a digital scan of the patient, and now that patient's like, I want to do aligners. Perfect. What we do is we now take that scan, we upload it to Rayware Cloud, which is Sprint Ray's cloud platform. And they have an AI platform that will design a retainer in 2 minutes. They say 5, but every one I've done has been about 2 minutes. And it is a direct print retainer, meaning there's no model, there's no pressure forming, there's no anything like this. So I was excited to have Tom here because I'm like, all right, I as a dentist get excited about this, but I showed him these retainers that
blew my mind.
Direct print. What were your thoughts on these retainers?
I couldn't believe it. I mean, I knew it was in the process. Someone was trying to come up with it. I honestly didn't know that they were actually doing it yet. And I figured once they were made, they were going to be like really layered and like murky and cloudy and not clear. And these things were smooth and clear and looked awesome. It was crazy. I can't believe it.
This is going to change a lot of things, you guys. It opened this door. Like, my team members, there's certain things I get excited for, like 3D printing, everything 3D printing I get excited about. But this was one of those advancements in digital technology that my team, when my assistants saw this, they were like, oh, thank God. I no longer have to use the pressure former, make the, use the mini star, the Drew format or whatever, make the suck down. I no longer have to trim it off, polish it, get it to snap, block out undercuts of the model, all this stuff. So like my team members are like super jacked about it. But where I started looking at this, I'm like, this is a great workflow for same day aligners, because now I can just take this scan, upload it, and directly print it. And literally the patient can leave after their hygiene visit with this retainer. Like, it's awesome.
I couldn't believe that was the same printer that you use everything else for. I thought they were going to have to make some more other specific printer that only printed clear aligners. And yeah, it was pretty legit. And I mean, think of the waste from printing a model and then sucking it down. And I mean, you're just avoiding all that, and it saves you money for sure.
And how much it's fun.
Yeah,
it is fun, you guys. Like, we work way too hard not to have more fun. And I'm always amazed. Like there's certain specialties or certain areas within dentistry, I'm like, you need 3D printers. Like ortho is one that I'm like, oh my gosh, you guys need to have printers. Like every retainer, every scan, like just to have that digital data. Like you guys all have Iteros.
There's so many that don't.
I know, it's
crazy,
nuts.
Yeah.
So the technology is moving really, really cool. As we kind of close up here, like, there are so many cool things coming with regards to aligners. And I think so many of us general dentists just think of aligners as like simple cases. And then we think anything that requires complex movement has to be brackets. talk to us a little about some of the cases and some of the techniques you guys are using in your practice that allow you to do these crazy movements with aligners.
Yeah. So you can do some pretty crazy things with aligners with the right attachments. I know we kind of glazed over attachments, but if you understand, there's actually a book by Barry Glazer that is Invisalign based that he wrote, I think maybe 8 years ago now, but it is really easy to read, and I recommend it to all general dentists because it's just like a really basic concept on attachments, tooth movements, force systems, and aligners, all that, and it's so easy to read. And so I think that's a good way to start. But right attachments, okay, you can totally level a curve of speed with aligners. It's hard, and you have to have a patient that's dedicated to it, but you can do it. It's really cool, right? And TADS in an adjunction with aligners is super cool, right? I've done some gummy smile cases, and we've gotten some intrusion out of it. I've done some posterior gummy smile stuff where you have TADS in the posterior, you're intruding with aligners and elastics, and you can close spaces with extractions as long as you have the right attachments and the right movement sequences down. And again, patient compliance, right? If they're not wearing them, it's not going to work, but if they do, it's pretty sweet.
Well, I think that's one of those areas that I hope you guys are hearing this and going either A, yep, this kind of makes sense, this is why I like aligners, or B, you're going like, my orthodontist doesn't do this or stuff. And if they're not, open it as a conversation. Like, hey, did you know that we can do these things? Or talk to us like what they're doing in their practice, or find another practice that's doing these things. I mean, there's just so many things that we can offer our patients in this digital world that allow our patients, that reduce the barriers for them to say yes to the best and get them into the treatment that they need without having to feel like they have to go brackets. Like, there's just so many opportunities. Not that brackets are not eliminated. Like, there's so many cases that I would say 50% of my cases are still brackets, but it's one of those situations that we have so many opportunities to impact people's lives, but we need to understand that if we as clinicians do not inform or let our patients know what's possible, they will not come to us. Your patients are not going to come to you saying, hey, Dr. Joe or whatever, I really don't like this rotated tooth. Can you fix this with clear aligners? What you need to say is, hey, pull up their digital scan, say, hey, have you noticed this rotation here? Just show them. And they're like, man, do you see how the plaque is just really building up these areas and the calculus built? Like, if we could just rotate this tooth a little bit, it'd be amazing how much easier this would be for you to keep it clean. Yeah, not only that, it's going to look better. Yeah. Did you know we can do this in our own office? And you'll be shocked with the perception of your patients. You'll be shocked, but you got to be able to tell them and have the conversation. And I think, as we talked about, you need to have a case selection. So there are times for those green light cases, go for it. But those yellow and red light cases, that's when you want to really start leveraging your team. And one of the things that I am a big advocate for is utilizing your orthodontist. This is why I wanted Tom on the podcast tonight, because he's one of my local partners here in our community, is that you need to have a relationship with your specialists.
And get in over your head.
Oh, man.
Reach out. Totally.
Or if you have a ClinCheck that you're like, shit, I think I may have bit off more than I should. Guess what? I'm not going to go like, I can't do it. I'm going to reach out and be like, hey, man, how should I approach this? And then you're going to, probably tell me I'm an idiot, but then you'd be like, all right, well, try this. And then if it works, great. If not, then send them more.
Yeah. But I mean, that's what we're here for, right? Yeah. And I think that's where a lot of dentists, they get like this prideful thing where they're like, I'm going to do it. And when then they see someone come back and it doesn't look good and they don't know what to do and they just keep trying and then it gets even worse, right? So just reach out to somebody. I mean, there's certain things that aligners can't do. And sometimes you need to put braces on. I mean, we run into it all the time, and don't be afraid to send it to your orthodontist or call them and be like, hey, here's where we're at. What do we do now? And then figure it out. I mean, you gotta have the patient's best interest in mind too.
Dude, I love it, man. Thank you so much for being on here tonight. This has been a blast. I feel like I could talk about aligners all night. But, if our listeners are like, hey, this orthodontist is pretty cool, I want to pick his brain a little bit, how can people get a hold of you?
Okay.
Are you on Instagram?
I am.
Right.
I'm trying to think what my Instagram is, though. I think
so. He's clearly not active on Instagram. We're going to work on this.
It's at Tom Welk. I'm pretty sure. At Tom Welk. Yep. Not Thomas Welk. At Tom Welk. I think I'm on Twitter at Tom Welk, too. Facebook, Thomas Welk. And you can email me, too. thomaspwelk@gmail.com.
Awesome, you guys. Well, if you do want to get a hold of him, please reach out, dude, man. Thanks for coming on.
Thanks for having me.
For everybody else, I hope this was useful for you guys. This is one of those topics I love. If there's some topics you want to hear about more, you're like, man, I really like this topic or that, reach out to us, send me a link. For those of you that are return listeners, thank you so much. For new users or listeners, welcome. And for everybody else, like, hey, if you like this, tell your buddies, tell your colleagues. This is how we share the word, and we kind of do more things. So until next time, we will check you guys later.
If you enjoyed this episode, be sure to subscribe so you get notified when all the new content is released. And don't forget to rate, review, and share this podcast with all your friends and colleagues. For more information about all things happening within the 3D Dentist family, follow us at www.3d-dentist.com. Thanks for listening, and I hope you are leaving with new insights to help transform and level up your practice. Until next time, keep smiling.